or the person who is or is not recommending colonoscopy. And there's also some systematic barriers. So we know that from just general data that those are some three areas that we need to concentrate on. So it'll be interesting to see how our own data bears out. Also, a goal is to educate lawmakers and be an advocate for sustainable sources of funding. Screen 600 underserved patients for colorectal cancer in Georgia and in Maryland, and currently we're slated to try to screen 300 patients in both respective locations. Complete a free web-based playbook to increase colorectal cancer screening and follow-up rates. The project is funded with a grant from Exact Sciences and support from Ironwood Pharmaceuticals and Braintree Sabella Pharmaceuticals, which we are very grateful for that financial support. Next slide. So what are some of the next steps here? Number one, to complete screening patients for colorectal cancer, ideally by the end of 2025. To continue to advocate for a sustainable source of state funding to screen uninsured patients for colorectal cancer in 2025 and 2026. Apply what's learned in both Georgia and Maryland to create the free web-based playbook, which I mentioned earlier, to increase colorectal cancer screening and follow-up rates across the U.S. So to create something that another entity can easily pick up and follow and follow through with the overall goal of decreasing colorectal cancer screening in these increased screening in these at-risk populations, and continue exploring ways to work with the Maryland Department of Health, local health departments, and healthcare systems or providers to participate in ASGE project. So that's sort of the goals of the program and sort of next steps. So with that, to that end, I'm going to pass the baton over to Colleen to tell us how her team is doing in Maryland.
Hello, everyone. For those of you who do not know me, I am Colleen George from MedChi, and I will reiterate what Jean said and thank ASGE for this opportunity for this very important work. We have been working with a practice out in Western Maryland that has a great deal of uninsured patients. And so far they have ordered 88 Cologuard tests. They've had 34 resulted tests. And the interesting thing about it is they have zero positivity rate. And that's, I think, something that all of us are scratching our heads about and wondering, why the positivity rate is so different between these patients and the Georgia patients. Next slide, please. So the majority of the patients from this practice, it's Medical Family Practice, in Frederick, Maryland, which is in Western Maryland, are uninsured, and approximately 11% of the population in Frederick County are immigrants. That's not a statistic that I knew prior to beginning this project, so I found very interesting. The practice has one Spanish-speaking care manager who's been making all these outreach calls. We are in conversation with the practice and a former MedChi employee, as a matter of fact, who is Spanish-speaking, to assist the practice so we can get a little further along with the in reaching out to these Spanish-speaking patients. Next slide, please. So, but one of the concerns with these Spanish-speaking patients is the recent changes at the federal level, and are these patients going to be more reluctant to participate in this program, sign the participation agreements that they're required to sign, come into the practice. So that is a concern that we are, want to be cognizant of and make sure that the practice and the patients are comfortable. We have identified an additional practice with the hope to expand the project to more practices with uninsured patients. I'm getting together with Tom this week to get that additional practice in the review and approval process, which we know takes a little bit of time through Exact Sciences. So I'd like to get that going. So we're going to get that going this week. So we have another practice that has a significant population of uninsured patients. Next slide, please. And that's it for me. Thank you. Please let me know if you have any questions at all or anything that I can do to further assist.
Don't think Senator Zucker has made it on now. I think he's on another call. But as soon as he's on, are you on, Craig? No, why don't we go ahead and skip ahead, Diana? We'll come back to him.
I have a question for Colleen. Hi. I'm
Yes.
Charlotte. I joined late. I work with Brian at Maryland Department of Health. So with the practices and they're using Cologuard, right? Remind me, I might have missed it. The practices, did they like bulk order Cologuard, or are they individually enrolling people into Cologuard's financial assistance program, or is this like blanket approval for these patients that they qualify for Cologuard?
It's a blanket approval that they qualify for Cologuard, but the practice does not have any of the Cologuard tests in-house. They send a request for the Cologuard test to Exact Sciences, and then Exact Sciences sends the Cologuard test directly to the patient.
Okay, so it's kind of like the FQHC model. Are you familiar with that?
I am.
Okay, right. So they basically don't have to do an individual application with a patient. The practice itself is saying, we know this patient is uninsured and low income, so Cologuard has agreed that they're going to just,
right.
if an order is placed, they're going to give them a
correct.
Okay, cool.
Correct.
Awesome.
And this has been worked out directly. This is part of what the grant is funding from Exact Science through ASGE, is to set it up. And then we're blocking a certain number of kits for that particular practice.
Oh, but what would happen after this funding ends?
It's a question I can't answer.
Okay.
That's a very good question that needs to be answered. And I know that a lot of the health departments, and you're probably aware of this, are creating their own types of screening practices. And we've talked to some of those health departments. That's something we really need to figure out.
So if I can give like my guidance is that the reason they approved the like blanket agreement with FQHCs is because they kind of have an understanding that FQHCs are going to send them their insured clients. So it's kind of like a deal. Like if we're going to send you insured clients, you're going to see our uninsured at no cost. So I feel like that's like the same thing that these private clinics have to do is, hey, after this program,
Well, we got to be careful about saying that in a meeting like this. I think that's, I'm sure that's not how it's really working, because so we can maybe talk offline about that.
This is Dr. Menacall. I'm checking in. Sorry, I was busy. Hello,
So I thank you, Dr. Menacall. Dr. Menacall is the actual practice where it's going on. So, but yeah, no, I'm sure that nobody's making deals where they're shifting patients based on doing tests or things like that. That's not happening at all. I know that's not part of the deal. The tests are paid for specifically by the grant, and that's how it works with, at least with our program. I can't speak to other programs, but
right. I know because you guys are private, right?
This is Gerardo Brooks with Exact Sciences. We do not have any quid pro quo arrangement with this health center or with any of our other health center partners. We, as part of our health equity work and our access to care work, we provide Cologuard through our patient assistance program to patients who have financial need, period.
Shamisa, what am I being accused of?
No. There's no accusation, Dr. Medical. No. We're talking about a different program that the person from the health department brought up. So, and it was just, I think there was a little confusion. That's all. But no, it's everything's fine. So luckily, it's just a question that caused some confusion. But no, everything is straightened out now. So perfect timing. The question caused us to have enough time, and Senator Zucker is here, and he's going to talk about the budget issues with regards to colon cancer and what's going on. And for those who don't know Senator Zucker, He is an incredible advocate for healthcare in Maryland. Senator Zucker was when he was in the House of Delegates, he chaired the Health Subcommittee on Appropriations, and now he chairs the powerful Capital Budget Subcommittee on the Budget and Taxation Committee. But he always spends a lot of time focused on healthcare issues. So without further ado, thank you for popping on. And if you could give us a little update on what's going on with colon cancer funding and funding around those issues.
Sure. First, can everybody hear me okay?
Yes.
Great.
Yes.
Great.
Yes.
Wonderful. Well, Jean, thank you very much. And I know you have a busy day today. I want to I see my colleague Delegate Cullison and Delegate Dr. both Delegate and Dr. Hill, as well as I think either Senator Lamb is on or will be joining soon. So nothing could be done in Annapolis without the great team that's on this call and represents you in the State House. Jean, to your question, what I want to do is just quickly just tell a quick antidote and then kind of get into part of the reason why I'm here. So I'll never forget a story that I heard years and years ago regarding an oncologist who had a patient come in who had cancer and they had no money, no medical, no nothing, and they needed basically free medical service, and the doctor was going to help, but said, "Look, happy to give you free medical service, but I've got a question for you. I have one real eye and one fake eye. If you can guess which one is the real eye, I'll give you service, no problem." And the person responded, I know which one is the real eye. It's the right eye. And the doctor said, "How did you know that so quickly?" And the person said, "Because that's the eye that had the warmth in it." And the reason why I tell that story is that it's interesting is I remember when my father was dying of cancer back in 2015, how much Dr. Cullen was helpful from Greenbaum, because it's just more than just treating the patient. It's also about the dynamics around the entire family. And I know that a lot of what you all are doing in specifically this area of colon cancer is protective. It's preventative medicine. And just from my own experiences and based on the fact that you've got wonderful leaders like Jean and tremendous allies like Bonnie Cullison and Terry Hill and others, it's been a major priority of the General Assembly to protect cancer research and cancer funding, especially around the Cigarette Restitution Fund. I could tell you that they would have had to take a train and run over me, and I would have still been okay to try to protect CRF funding when it comes to uh, cancer research and combating this disease. With that, we restored more than $15 million in CRF that will obviously help Greenbaum and Kimball. And as Jean mentioned, with my position as chair of the Capital Budget Subcommittee, we wanted to make sure that we invested more than 25 million in the bricks and mortar capacity of of cancer facilities like the University of Maryland Medical System. So I think just in terms of what's going to happen this next session, I think that the gauntlet has been put down in terms of the General Assembly as a whole viewing this as a priority. I think that right now, given there is a lot of chaos coming from the federal government, structurally speaking, we have more than $2.5 billion worth of B, both in cash, what we have in the bank account, and then what we have in our rainy day fund, which is our state savings account. So we are going to continue to do all we can to protect CRF funding to make sure that it's available and going to preventative medicine. I think there's so many lives that can be saved with the dedicated people on this team, as well as the funding that you're getting both from the public and private sector. The thought process for us in government, certainly from my thought process, is work with my colleagues to provide the resources that you need, and then just stay the heck out of your way while you provide these services. And so I wanted to come on personally. Gene, thank you again for the invitation. Dr. Adams, just to salute you all and thank you for everything that you're doing. You know, I say that you don't need to be in elected office to be public servants, and every day you all are saving people's lives. And on behalf of the 133,000 people that I represent and on behalf of the state of Maryland, we're just internally grateful.
Thank you so much, Senator Zucker. Really appreciate you being on. I did also want to note that I've seen a couple other legislators on. I see we have Vice Chair of the HGO Committee, Delegate Cullison is on. I see that we have the Chair of the Finance Committee, Senator Vidal is on. I'm sure I'm missing a few others who are on as well. Delegate Taylor, Kim Taylor, and Senator Lamb and Delegate Hill are next on the agenda to speak. So I guess in fairness, since we just had a senator speak, I should let Delegate Hill speak just so we're balanced. So Delegate Hill is a private practice physician from Howard County and is on the Health and Government Operations Committee. So Delegate, I'll let you go first and then we'll let Senator Lamb speak after you. Okay.
Thank you. Thank you, Gene. So I want to add my thanks to the ASGE for the work that you guys are doing, the screening program initiative, and how much you are committed to it. And frankly, for inviting us to participate in this conference. And mostly I want to listen in for as much of the afternoon as I'm able to participate, which is not much longer. During my surgical training 30 plus, almost 40 years ago, I myself performed colonoscopies. And I remember at that time just being amazed that we had this one thing, you know, where we could remove a precancerous polyp and absolutely prevent a cancer from occurring. And that in the 35 or so years since then, we're still having challenges getting that message across to the public and getting them to understand. I think here in Maryland, colon cancer remains, I think, either the number 2 or number 3, some of the data is old, cause of cancer deaths. And between 50 to 65% of the cases that are found are late stage, right? And depending on your county. So that's clearly a problem that you all are committed to addressing. And Senator Zucker spoke to our budgetary and financial commitment. And obviously, it's going to be a lot harder than it might have been in years past to make sure that we identify the dollars when we lose our federal partners. It makes everything that much tougher. But I think, and my vice chair, well, I'm sure will, give some more details, that I think I can speak for all of us that we're committed to doing everything we can to help identify patients early, and not just through screening, but to find the programs to help them get the appropriate next steps test. It doesn't matter if we screen better if we're not able to help people, particularly of marginal income, to actually get the procedures, the surgeries, the radiotherapy, the chemo, whatever it is that they need to treat the disease. But we can't do that if we're not identifying them. And obviously, the earlier we identify, the better we all are. And I think that we understand that legislatively, often the best arguments that we're able to advance are the ones that say, it looks like
let me have a Southwestern salad.
But you're saving money in the long run. So when we can show the state, we'd love to think that it's about caring about people and caring about health. But all too often, it's about showing the state that we save dollars in the long run by early detection, prevention, and early treatment. So I thank you again for all you guys do and having me here.
All right, and just I've missed a bunch of other legislators who are on. Delegate Wu is on. Senator Karen Lewis Young is on. Delegate Vogel is on. Delegate Tavares is on. Senator Augustine is on. Senator Benson is on. And then Delegate Ruth, who everybody should look in the chat and see what she had to say, is also on. Senator Lamb, you're next in the queue, and we'll obviously have an opportunity to uh, um, to do question and answer. Anybody else can talk who wants to at the end. So, Senator Lamb, go ahead.
Yeah, thank you, Gene. Thank you to the Society for the opportunity to speak here. Always great to be able to kind of communicate what's been going on with the General Assembly. I know my chairperson, Senator Bidle's here too, just a tremendous champion advocate for health-related issues. As we serve on the Senate Finance Committee, you may hear about Senate Finance. It is, even though healthcare is not in the title, all of the healthcare-related bills come through Senate Finance Committee. And so, we have a good perspective on things that are coming up. To all of you, really impressed to hear about what you're doing with colorectal cancer screening. I myself am a physician, still see patients every week. I am a residency program director for the preventive medicine program at Hopkins in my job outside the legislature. And so when it comes to prevention and screening, the work that you do is really, really important to be able to keep people healthy and address some of the upstream social determinants of health as well. When it comes to colorectal cancer in Maryland, we know that there's still significant progress that needs to be made, as Delegate Hill mentioned as well. I think we have an incidence rate of colorectal cancer in Maryland at about 34, 35 people per 100,000. So, I think it is the second highest cancer diagnosis here in the state. And more than half of the cases, as Delegate Hill mentioned, I think it was well over 60%, are caught in the later stages of cancer. And so that's challenging because we know that if you're able to catch it much sooner, you're able to have it be much more treatable and the outcomes are much better. It's a challenging environment right now because of a lot of the cutbacks in support from the federal government. That's going to make screening efforts and efforts to be able to treat colorectal cancer a little bit more difficult. You may have heard of some of the changes because of the Republican tax bill that was passed impacting Medicaid, and we're expecting probably, well over 100,000 people being ejected off our Medicaid program in the state. That will make it more difficult for them to get screened and get treatment that they need, and more people will be uninsured. We're also, if you're following the news closely in the last few days, concerned that there is a federal body called the U.S. Preventive Services Task Force that are seated by members that are experts in epidemiology and in the study of how cancers and screening should be guided throughout the country. So they put out national guidance. And that task force, which has been present for the last 20 or 30 years, probably even longer, is at risk of being disbanded by RFK Jr. as the Secretary of the U.S. Department of Health and Human Services. And so there's very real concern about how that could impact screening rates because the recommendations from that task force are required under the Affordable Care Act to be covered fully by health insurance companies. And so, if the U.S. Preventive Services Task Force is disbanded and their guidance is no longer being updated, how could that impact our screening and guidance and requirements for insurance companies to cover screening for our patients could be negatively impacted. And so through leadership of folks like Senator Bidle and others in the House as well, we have been able to pass legislation this earlier this year that will require state regulated plans that are regulated by the state of Maryland, the Maryland Insurance Administration, to still cover screening for any recommendations that the task force had put out as of the end of last year, as of December 31st, 2024, in anticipation that something like this might happen. So basically freezing any of the recommendations and guidance out of the task force at the federal level as of the end of last year to still require our state insurance companies to cover that moving forward. So hopefully that will be a Band-Aid that will help address the needs when it comes to things like colorectal screening moving forward. But we're seeing, a rapidly shifting landscape that could be really troubling, not only on the Medicaid front, but also we just had a briefing yesterday on SNAP that Senator Bidle and I were on. It could be a $400 million hole just to be able to keep our SNAP program status quo, that the state would have to find another $400 million plus to be able to keep SNAP benefits for people to be able to put food on their table. So whether it's that or the potential loss of our rate setting ability for our global payment system, for our hospitals, lot of, bumpiness coming down the pike when it comes to our healthcare system. But, know that, through leaders like Senator Zucker and others and Delegate Hill and so many other legislators that are here, we're really cognizant of this, and we're going to do everything that we can to continue to protect, Marylanders, their ability to be able to engage in screening and preventive practices and, to support those who need health insurance. So why don't I stop there because I know we have a lot of colleagues here. Happy to pass it back to Gene.
All right. Well, I have two more legislators. I missed Delegate Phillips, and also I see that the vice chair of the House Budget and Taxation Committee, also Delegate Chang, has somebody on. I can't miss him. He's an important guy. So I'm not doing a very good job with the announcing the legislators on Zoom. This is not easy. So maybe one of the chairmen, like Senator Bidel or Vice Chairman Cullison, can tell me how to do this better. Anyway. Before we move into the presentation from Brian from the health department, I did want to recognize Dr. Menikow. Now, I've known Dr. Menikow now for 25 years. He has volunteered his practice in Frederick. And let me just say that since the time I first met him, Dr. Menikow is one of those guys where he sees a fair number of people who don't have insurance and doesn't expect a thing, and he really cares about his patients. And when you meet one of his patients, you realize they really love him. So thank you for doing this. He's not getting any remuneration or anything for it. He's just doing it because it's the right thing to do, and we really appreciate it. I don't know, Dr. Menikow, if you wanted to say anything real quick or not. You don't have to if you don't want to, but we really appreciate you offering your office, and your time, and your care managers to help us provide these free services.
Yeah. No, thank you, Gene. Now, I think it's working better than I thought it would. Um, we're offering it mostly to undocumented immigrants. So we thought there was going to be some resistance for these undocumented immigrants who are really the only people who don't have insurance coverage now. There will be some resistance in having their names and addresses part of a database, but there's been no resistance to that. And it's been, I think, out of 400 we've sent out, we've had 100 replies. So far, none of them have been positive. So the community's accepting this. 60% of what I do, Senator Lamb, is Medicaid. So I'm looking at these coming changes, and I'm thinking, what am I going to do? But you got to do what's right, and if that makes you broke, then that made you broke, but you can't do what's wrong and expect to have a life you feel proud of. Having said that, we're ready for the Medicaid changes coming down the line, and we're going to expand our services to 18 hours a day, 7 days a week, realizing that Medicaid recipients do not need to pay co-payments if they get seen through my office. And we're going to plan to provide semi-urgent care and specialty care as well. So we're going to get that ramped up for the new year. But it's exciting. Thank you for allowing us to participate. We have two community health workers on this who are very judicious about this, and so far it's been good. Thank you.
Well, thank you, Dr. Menikow. And just though, if anybody missed that, Dr. Menikow's practice is 60% Medicaid, and he sees a fair number of uninsured people that he just sees. And he has been like that since the day I met him 25 years ago or whatever. He really cares about the people in Frederick and the people he sees, and he's actually expanded his practice to some other areas of the state that needs help as well. I wish we had more of you. You're really a blessing to the state. Thank you. So Brian, I'm going to turn it over to you to go ahead and give an update on the Maryland Department of Health, and the best screening is the one that gets done. Go ahead, Brian.
Great, thank you. Thank you for the ability to join this meeting. For those who don't know who I am, Brian Mattingly, I'm the director of the Maryland Comprehensive Cancer Control Program. Next slide, please. So real quick, the challenge and some of the barriers we're seeing for colorectal cancer screening in Maryland. I would describe it as an over-reliance on colonoscopy, seen as kind of the standard for screening, resulting in limited adoption for non-invasive tests like FIT and FIT DNA tests. There's a GI gastrointestinal specialist shortage in Maryland. and throughout the nation. This was confirmed by a study done by Johns Hopkins last year, a geospatial study, and you'll see that study next to it along with the map, one of the illustrations from that study. There are long colonoscopy wait times of over 12 months in some areas of the state. Also, there's disparities in late stage diagnosis when these persist when you compare with other cancers. And also there's funding constraints, limited screening funding, limiting reach for the uninsured in Maryland. Next slide, please. So we've looked at expanding access through what I call innovation and collaboration. So regarding expanding access, enhancing patient access. So in Maryland, we partnered with Exact Sciences to offer no-cost Cologuard test to average risk, low-income, uninsured patients through the local safety net cancer screening programs. And also this was gave us the ability to really optimize our financial resources. This agreement will maximize impact by extending a limited CRC screening budget so we can serve more residents in Maryland. And for some of you on the call who may not be familiar with Cologuard, kind of why we went with Cologuard, a simpler ordering process. It's quick and seamless through this agreement. It's basically they click a button and the test is ordered. Exact Sciences had a built-in patient navigation where once you do the order, they manage reminders, guidance, and routine recall. The current Cologuard test that's being utilized has high clinical performance with a 92% sensitivity and 87% specificity for colorectal cancer. I understand the Cologuard Plus test, which is being rolled out as the older test is being I guess they're finishing this store of tests they have, has higher sensitivity and higher specificity as well. Also, it addresses some barriers with at-home convenience. There's no required prep time that you'd have with a colonoscopy. They don't need to take time off of work, just to name a few of those barriers. It has the potential for improving screening equity, which would lead to higher completion rates and reduced health disparities. And also, financial assistance is available. The cost is waived for eligible low-income patients. Next slide. So additional work we're doing in this space, and this is really the credit to our Maryland Cancer Collaborative, our cancer screening work group. We've taken this approach of the best screening is the one that gets done. And some of you may have seen this. The work group drafted a letter, which really kind of illustrates the challenge in Maryland with limited GI specialists and long wait times, and really just emphasize that truly the best screening is the one that gets done. So with this promotion, this letter promoted non-invasive screening for patients at average risk. In order to really decrease colonoscopy wait times for patients at increased risks or needing a diagnostic colonoscopy. And also it offers an alternative for patients reluctant to colonoscopy, who have maybe fear, anxiety, or preparation concerns with colonoscopy, and also reduces a lot of the logistical challenges regarding time off work, transportation, to name a few more challenges. Next slide, please. So as far as what's next, some ongoing priorities are around education and clinical integration. So really enhanced clinician training to proactively discuss all the options for CRC screening. Really, we'd love opportunities to get out there for any meetings or trainings, arranging speakers to come out and talk on this topic, promoting effective tactics for integrating non-invasive screening into clinical workflows and quality improvement efforts, and really just reducing colonoscopy wait time with better triage of patients. And also a new initiative that we're kind of working on now is a pro bono colonoscopy pilot. So I've talked to various clinics who have been screening low-income uninsured patients. And for those who have suggested findings as a result of non-invasive screenings, they need to have a colonoscopy, but there is not enough free colonoscopies to go around. So we're looking at building strategic partnerships to develop a scalable model for delivering pro bono colonoscopies, enhancing robust patient navigation and support services to improve screening adherence, and also establishing streamlined referral pathways for patients diagnosed with cancer to access timely treatment and care. And also another initiative we're looking into is enhancing colonoscopy result sharing. So really having conversations about how to improve patient care coordination and health outcomes through consistent and timely sharing of the colonoscopy results. Next slide. So if anyone feels like they want to reach out to me, any questions or interested in some of the work we're doing, or if you haven't seen the letter that we put out and like me to send you a copy, here's my contact information. Feel free to email me at the state. So thank you very much.
Thank you. That was great. And really appreciate all the work the health departments have been doing. We've seen a definite uptick over the last 4 or 5 years where the health departments have been very focused on this colon cancer. And a lot of the local health departments actually have got their very specific programs that they're running. And we've actually talked to several of them about them and how they work. There were a couple questions in the chat that I was going to just address. We are looking at possibly adding additional sites so we get to the full amount under the grant. That's a possibility, but we really are focused on the uninsured because of the great work that the federal government and the General Assembly. There's no reason for an insured person not to be able to get this test. It should be covered, and if it's a problem, we want to know about it, and MedChi will help those patients file complaints with the MIA. And we really want to focus on the 6%, and unfortunately, it sounds like the number is going to be going up thanks to the thing that happened in DC a couple of weeks ago. But the 6% of the uninsured is who we really want to focus on. That's kind of our idea. So I'm going to open it up. Oh, one other person I need to introduce. I saw that about halfway through the meeting, Dr. Christie, who is the immediate past president of ASGE, signed in. Dr. Christie has been working with us since the very beginning on this, and she is wonderful. And I'm really happy to have her on the call today. That's great. So I'm going to go ahead and open it up for questions, comments, thoughts that anybody might want to say about this program or what we're doing on this, or suggestions on what we can do with regards to advocacy in Annapolis to help the health departments be more effective. We really want to see everybody get screened for colon cancer, and we want to prevent this. We were losing more people than we need to be losing. This is one of those things where if we can screen people early and get them to treatment, it can make a big difference. And this is one of the very preventable diseases. So any comments or questions, we're opening the floor up.
Thanks, Gene. This was a great discussion and conversation. I'll say that I, on behalf of ASGE, I think this is absolutely phenomenal support on the legislative side in terms of monies that are being protected to keep this rolling despite what's going on the federal level. So I thank all of you for your engagement with this and partnership. A quick question for Dr. Medicall. Just curious, are you seeing any new or early barriers to screening that we should address or know about so that we can increase the number of patients that are being screened?
Well, the biggest fear was that the demographic data could somehow be accessed by ICE. And that was kind of the biggest barrier. But as time went on and more people got screened, and they realized that their data was in fact safe and secret, then the program's taken on more impetus, if you will. The fear of cancer is so powerful that literally is more powerful than the fear of deportation, if you know my saying that. We've been able to work with our local law enforcement to ensure that our facilities are recognized as a safe space for patients to come and get their medical care. And that word has spread through the community very, very fast. I think the first 3 months of the year, we saw a dip in our volumes out of fear, but that fear has been conquered, I think. The next issue is going to be what happens the day we get a positive one, and we get about 1 out of every 300. And the question there is going to be, where are we going to get those colonoscopies done? And I know Right now, it's all the way down PG County, and the issue is going to be our radiant transportation. And we work with a lot of different local providers of transportation to provide transportation for patients. We actually will take them to and from appointments, even if it's out of county. We will take them to pick up groceries and pick up their medications at our own expense. So I think as things stabilize and all the noise of immigration quiets down, this program will really take off. And we've been able to develop a very strong relationship with the community that if they come here, they will be safe and their data will be safe and protected. So I hope that answers your question, Tanya.
It absolutely does. Thank you.
And just on the and Dr. Banks in Prince George's County, she is an active member of ASGE and an active member of MedChi. She said she would see anybody who needed a colonoscopy at no charge. So that is the and we can get anybody there. We have an agreement, MedChi's agreement with Lyft to take care of transportation. However, we have also reached an agreement where CDC, Capital Digestive Care, not the federal agency, Capital Digestive Care, who has multiple locations all over the state, is also going to be willing to participate. So when we get that first patient with that result, we're ready, and I've got care managers who are excited to roll on that. So next, with their hand up, is Mary Joseph. Mary.
Yes, I just wanted to, again, with Capital Digestive, and it was one practice, but a clinic actually reached out to them and was able to work with them to be able to provide colonoscopy for patients. The clinic had some grant funding that was left over. So, but some of the things they came up with that were difficulties were it wasn't just the doctor. The doctor was more than welcome to donate his time, but it was the facility, it was, the lab, it was anesthesiology. So, it was really eye-opening. Brian and I met with the clinic, and it was really eye-opening to see all of the difficulties that had to be worked through in order to get this colonoscopy. The doctor was the easy part to do. The other thing they did is, although it wasn't mandatory, they tried to get the patient to have some skin in the game by making them pay like $100 or $200 for their colonoscopy to make sure that they went to that colonoscopy, that they were really invested in it. So, it's a good program. It's a Mansfield Caseman Clinic in Montgomery County. And I think they were able to get like 10 or 15 because our county program was shut down all last year. So we really had no place to send the uninsured. But I just wanted to bring that up, that I think that it does lead you think, well, the doctor's going to give us a free colonoscopy, but there's a lot more involved in it. So I just wanted to say that. Thanks.
Yeah, and for those who don't know Mary is a consumer advocate in Maryland and is part of the Cancer Collaborative. So I think a lot of the legislators probably know who she is, but just for everybody else. So thanks for being on. And I think, the work you guys do when you're trying to help people out, that's very much appreciated. So it's something we're definitely going to need to work through. So Dr. Christie, I saw you took your hand down. You ready to roll?
Yeah, thank you, Gene, and thank you everyone for joining. My, I guess, follow up to what Dr. Menachal was saying was that, clearly there is a sense of trust that your community, your patients have in you and your practice, and that I think that really, quote unquote, trumps the fear of being undocumented. So I wanted to congratulate you for that, and I think that's a really important element in how to get these patients in, is that trust that they have in their providers and in the healthcare system, and that's something that we all need to continue to work on. And then the second part about I think it was Mary Joseph, and then Dr. Adams brought up the follow-up colonoscopies. So you mentioned the Capital group, and then Dr. Menachal, if you had any other suggestions with providers closer to you and your patients that we could partner with, just continue to let us know that. And you don't have to come up with that now. I just wanted to reemphasize that.
Correct. And one of the strategies I use when again, to sign up for MCOs, for example, is if you help us out with the MCO business, we will give you all our other business, which is the commercial business and the Medicare business. I think just making this test available for free for people without insurance is such a big deal, such a change in their life that this program is paying for itself. Nothing's more devastating for an immigrant than to have a life-limiting illness like a colon cancer or a stroke or a heart attack because it impedes their ability to send money back home. And that's really why most of these people are here. They want to send money back home. So this program is great, and we look forward to expanding it. I wish we were a little more nimble. We see a lot of walk-ins, and sometimes they get a little confused that we're seeing it for an acute problem, but now we want to talk about colon cancer. But most of them are receptive, and it's worked a lot better than I thought it would. So it's a good deal.
All right, Dr. Hill, or I'm sorry, Delegate Hill, Delegate Dr. Hill.
Thanks. So I really wanted to, first of all, congratulate everyone who's been involved with this. And second, I really wanted to ask for someone to expand a little bit on the issues that Mary Joseph raised. So what are we doing, or do we need, is there a legislative intervention that's needed or even possible for the people who are, have a physician who's willing to do the colonoscopy but can't get a facility and anesthesia, or who have a colonoscopy and then need additional treatment and are uninsured? I kind of would like if someone could help me to understand better what these additional bottlenecks and roadblocks are, so that I have some idea of where we might need to adjust our focus a little bit as a budget.
So Delegate Hill, so what Mary was referring to is if we find a GI doc who's willing to do a colonoscopy for free, the issue is that there are three contracts really. There's the anesthesia company that they use, which will be a separate entity. There is the facility, which will be a separate entity that the GI doc might or might not have an interest in, usually has an interest, but isn't the majority interest, and oftentimes might be owned by a large corporate partner or a hospital. So it can be challenging then to get all three parties to agree if you have an MCO patient and maybe they aren't taking Medicaid, or if they're uninsured and you're trying to do something for free. So I think what she's running into is it's not just enough.
Right.
I think she was saying it's very easy to get the individual doctor to say, yeah, no problem, I'll do it. Sometimes the other two entities can be more corporate or colder or difficult. So that's the one issue on that one. And then what was your second question?
So I understand that's the exact problem.
Yeah,
what
right.
I'm interested in with this group is what are the solutions that we're looking at? How are we dealing with that situation now? And is there a role for the legislature in trying to resolve this? Because it suggests that, there are people right now who are stuck. They've got someone willing who's not able. I mean, when I trained, we administered our own, anesthetic for our colonoscopies. But if the facilities aren't willing, what are we doing about those folks? And what plans are being made, or what plans need to be made? That's what I'm asking about. I understand the problem.
It would seem to me that there are two big issues. For the uninsured, it is really important that we make sure that there's appropriate funding in these public health programs. I actually think the health department, particularly under this administration, has been very focused on trying to develop good programs at the local level around colon cancer. We want to make sure they're funded, because that's how we deal with people who are uninsured. With regards to Medicaid, I think the issue is that it's really important that we have adequate networks, and that we hold, that we make sure that we're not just checking network adequacy at a superficial level, and that we make sure that they have an adequate number of facilities that take Medicaid and take the other practitioners that are necessary. Because that's one of the biggest issues, is that when you're trying to find a patient who's a Medicaid patient that's been identified for a full colonoscopy, is making sure that there's a network. So those are two fixes that I think we could look at immediately to help solve the problem with regards to making sure that people of limited means and then people of no means get access to it. The other point I would make, and this is something that we've already had a bigger meeting on, I'm very concerned in 2026 when the re-enrollment requirements that were put down that were by no means beautiful at all, because all they're going to do is throw people off insurance. We have got to work with practitioners to help these patients get re-enrolled immediately so they don't lose their insurance, because that's going to just exacerbate the problem, not just with colon cancer, but with other things. But I think that's a third thing that we need to be thinking about today. And how do we educate practitioners, not just FQHCs, but also hospitals, physicians, other places where Medicaid patients interact, because that bill has two major problems for Medicaid patients. One is that it makes them fill out forms every 6 months, almost in an abusive way. And then secondly, they've changed the retro payment from 3 months to 1 month. Now, those things are both lagged for a year, and I can send more info on that. But I think that's a third thing that we need to do some work on to address this issue, Dr. Hill, Delegate Hill. Sorry. I want to call you doctor. That's higher than delegate, I think. But anyway, all right. Senator Benson. Oh, you're muted, Senator Benson. There you go. Yep.
Thank you all for this presentation. I think it's absolutely wonderful. The question I want to ask is, you all do the screening, and from what I looked at in this presentation is the time that it takes for the results to get back. You all were talking about months at a time when the information or the screening is sent in, and the results of the screening is creating a problem. Can you all comment on that for me, please?
My experience has been 3 weeks.
Dr. Medical, go ahead.
I'm sorry, Senator Benson. My experience in my practice, and again, we run three sites in Maryland, is 3 weeks is the delay once the patient sends the test in. Now, once you order the test, that doesn't mean that the test gets done that day. That the patient receives the box, and then they have to proceed and send the specimen in. Once the specimen is sent in, the delay is about 10 to 12 business days. So there's many areas where there's that delay. There's a lot of confusion on how to collect the specimen. And we see a lot of people have to send it 2 and 3 times because they put it in the wrong container. They seal it incorrectly, and the UPS or USPS will not deliver these specimens. But once all that has been completed, the delays are minimal. So I don't think it's so much that the test is not being reported quickly. It's just that there's a whole process, a lot of informed consent, and a lot of processing specimens that just eats up a lot of time. There is a new test that is a blood test, but their results are really not that good. Cologuard is a much better alternative, and it's just convincing people and getting them over the fear of sending a specimen of their own feces through the United States Postal Service, and that is scary to a lot of people, and it's just confusing. They collect it wrong. Sorry.
Thank you very much for that.
And Senator Benson, that's a really good point. And that's why with these programs, not just the one that MedChi and ASGE is running, but also the ones the health departments are running, the care managers are really important, because you need those care managers to help the patients understand how to do the test or help get it in so you can reduce that time. But that's a really good point that you bring up. So I think we're coming to an end. So unless anybody has an urgent question or anything, I'm going to go ahead and turn it back over to Dr. Adams to thank everybody and for coming today.
Yes, thanks again, Jean, and everyone on this call. The legislatures, I mean, this has been an amazing show of support for the program, as well as, again, as I mentioned earlier, knowing that there's some level of financial support behind it. I think there's some nuts and bolts to be worked out, as Delegate Hill brought up, in terms of how do we sort of marry the issues of bringing in not only physicians who are very motivated to be involved, but also the pathology and anesthesia and those kind of elements. I think there's still some discussion to be had about that. But again, we thank everyone for your engagement today. I think this is we're off to not just a great start, because it sounds like we're well into it at this point. And hopefully by the end of the year, we'll be at a point of having the numbers we would like in terms of the 300 Cologuard test resulted. And last but not least, I can't thank Dr. Medicall enough for your support and your engagement, all you're doing in the community. This is it's very admirable and appreciated.
Thank you, Dr. Adams. Let's
Sure.
keep praying that our good luck holds up, and we are able to continue our mission without too many distractions. But this is what we deal with, and we have got to accept the realities of everyday to day life, and we are well on our way to completing our mission. All right, thank you, Dr. Adams.
Fantastic, and I look forward to meeting you at the site visit in a couple of months. So to that end, I thank
yes,
everyone.
ma'am. We'll see you then.
Absolutely. Absolutely. And to that end, thanks everyone again. And we'll see you hopefully sometime in the very near future.
Thank you.
Thank you.